can begin.
Good afternoon and good evening, everyone. I am Dr. Rahul Mandlik from Shalina Healthcare. Welcome you all to this program. Today is the 15th webinar in our educational series, which we have started more than 1 year now. And in today's webinar, our expert speakers, Mrs. Shilpa Joshi from India and Dr. Kibet from Kenya, are going to shed light upon some of the very obvious sounding causes contributing to anemia and how to manage them. So, with this, let me start with the overview of this webinar that we all are aware of that oral iron supplements are usually taken either empty stomach or with food, and both of these scenarios they have their own benefits and drawbacks. Like when iron supplement is taken with empty stomach, it is best absorbed. It is well reported. But the issue is that it may cause some GI side effects like cramps, nausea, and diarrhea. While on the other hand, when iron is taken with food, benefit is that there is lesser risk of GI safety issues, but at the same time, there is a compromised iron absorption. So it leads to a bigger question now to healthcare professionals for whether to recommend oral iron supplement, empty stomach or with food. And this webinar is going to answer this particular question. Very brief about us. Today, Shalina Healthcare is one of the largest pharmaceutical company in Sub-Saharan Africa. And from last 35 years, we have made it our mission of manufacturing quality and affordable medicines and to make them available across the region. And we achieve this by manufacturing our products at WHO approved facilities, and by keeping patient and people at the center, we are actively involved in a range of social activities to enhance overall society's health. So with this, let me welcome our expert speakers. Mrs. Shilpa Joshi, ma'am is a registered dietitian at Mumbai Diet and Health Center in Mumbai, India, and she is a national vice president of Indian Dietetic Association. She is also honorable secretary of All India Association for Advancing Research in Obesity. She is a course director of National Diabetes Educator Program. Dr. Shilpa has trained more than 3,000 diabetes educators, and she has presented at various national and international meetings like American Diabetes Association, International Diabetes Federation, International Co-Federation of Dietetic Associations, and she has over 15 publications on her name. They are published in peer-reviewed journals. Welcome, ma'am. Our next speaker is Dr. Kibet. He is practicing as a medical officer at Real Hospital in Kenya. And in the recent past, he was associated with Racecourse Hospital and Baringo County Referral Hospital in Kenya. He has completed an elective exchange program in the University of Alexandria in Egypt, and he participated in scientific conference held by Federation of African Medical Students, that is FAMSA, and he is participating in community-based first aid programs run by Kenya Red Cross Society. Welcome to Dr. Kibet. Now,
Thank you.
audience, flow of the program is I will hand over now to Dr. Kibet. He will talk on the problem of anemia with African perspective, and then Shilpa ma'am will take over and she will talk about how dietary factors they influence the iron absorption, and that is how the anemia. Followed by that, I will represent you. I will take up some of the questions raised by you during the program, and that is how is the flow. Please stay tuned. Thank you so much. Over to you, Dr. Kibet.
Okay, good afternoon, everyone. As Dr. Rahul said, that my name is Dr. Kibet. I'm a medical practitioner in Kenya, Eldoret. in a hospital called Real Hospital. I'm going to take a brief I'm going to take you through a brief discussion about anemia, and hopefully it is going to be a very informative session, and it's going to benefit some of our audience, and even in the process of managing our patients in each and every line that we happen to do. Uh, Straight to our slides. We're going to look at that. Hopefully, you're seeing. So,
Yeah.
anemia is a medical condition that is characterized
Dr.
by.
Kibet, you have to open your slides file, PowerPoint file.
Sorry. Yeah.
Yeah, and just go to slideshow mode.
Okay. Are we there?
Yeah,
Okay.
it's coming up. Yeah, perfect, right.
Nice. So, as I was saying before, anemia is a medical condition that is actually a major problem in the sub-Saharan African countries, Kenya included. We happen to meet patients with who are severely anemic in nearly daily basis in our healthcare facilities, and we really have a big challenge, and the health-wise implication of this problem is really felt in our facilities. It is by definition, iron anemia is a condition characterized by reduced iron stores and level of hemoglobin. Uh, we are going to look at one of the types of anemia, which is iron deficiency anemia. Of course, we have a lot of several uh, types of anemia depending on what causes it. For example, we have hemoglobinopathies. We also have enzymopathies. We also have problems that are associated with blood loss, problems that are associated with the reduced red cell production, and also problems that are rather what we call diseases of the bone marrow. Uh, so onto this next slide. So by definition, anemia is reduction of the hemoglobin concentration below the reference ranges, depending on where the authorities have quoted. Like for example, here in Kenya, we usually categorize anemia in three. We have moderate, severe, and mild. Anything that is below 4, we usually say that is severe anemia, of which we usually find patients in such cases. There is a particular place in Kenya called Baringo. Baringo is an arid and semi-arid land. Once in a while, you can find a patient or a pediatric child with an HB of around 2, and they are walking, which is actually significantly low. And that's where we say that man is severely anemic. And then HB of from 6 to around 8, that's where we say mild. And then, of course, over 10 to around 11, that's where you say, oh, yeah, moderate, and the other one is mild. So iron deficient anemia is a common type of anemia that is due to iron deficiency or lack of iron absorption or consumption in the diet. The table here below shows us the basic characterization or other classification of anemia, where in men, the normal, the range of 11 to 12.9, we usually say that's mild. And then we also have a range of around 8 to 10.9, it's moderate anemia, and less than 8 is severe anemia, which in Kenya, most of the time, we usually don't find so much with somebody having an HB of 8. In women, it is slight changes. In children now, that's where this classification of anemia based on the age of the child. A child of 6 months all the way to 5 years, at least we say the child is mildly anemic in the HB of around 10 to 10.9, and then 7 to 9.9 say the child is moderately anemic, and of course less than 7, the child is anemic severely. Pregnant women, of course, pregnancy is a demanding situation where there is what we call the hemodilution of the blood due to the growing fetus, and also the changes that do occur in the pregnant state. So we basically associate that as the hematological changes during the pregnancies, and once in a while again, you also find anemia in pregnancy, which usually has an implication in the growing child and the growing fetus as well, which needs to be addressed well through supplementation of iron during pregnancy in what we call antenatal profile in Kenya. Iron deficiency anemia, if you were to do what we call a laboratory test of examining or rather viewing the shapes of the iron individual red cell, you find that the cells are usually, they have a pallor, a central pallor, which you can actually see in our slides. Central pallor, the bigger the central pallor definitely means that the cell is less concentrated with hemoglobin. That's what the slide tries to say. Globally, these are statistics that have been established. 1.6 billion people are living with anemia, and by population, preschool age children, age between, of course, now preschool basically means the child is less than 5 years of age. Prevalence of anemia goes to around 47.4%, and that's is almost equivalent to 293 million children who are living with anemia. School age children, probably around 10 years to around 5. Uh, the anemia prevalence is around 25%. In pregnant women, it rises up to around 41%. The non-pregnant state is a bit lower. Probably this one again explains what I was trying to say that earlier on, in that in the situation where the mama is pregnant, or rather the mother is pregnant, there is a there are some I would say the processes and other changes that do occur in during pregnancies are demanding more blood and more iron, and also the uptake also needs to be more evaluated. In men, 12.7%. Probably this one can be explained by the fact that men do not shed blood probably monthly during their monthly periods as compared to the female gender. And most likely you'll find few male are likely to have anemia compared to the female gender. In the elderly, around 23% prevalence. And that gives us a total a prevalence of around 24.8% globally. It comes to the prevalence of anemia. And that one is at about 1620. That's one, probably 1.6 billion people living with anemia. Anemia, the prevalence in Africa. The World WHO has established some particular data that are as far as anemia is concerned in Africa. In the pregnant women, the prevalence is around 45%, and the age group between 15 to 49. Probably this is the childbearing, and the premenopausal age group falls in between that. Women of childbearing age, again, that one goes to around 49%, 40.4%, and children of 5 years, 6 months to around 5 years, it rises up to 60.2% prevalence, of course, due to some various reasons. Sampling some few countries in Kenya, Ghana included, Kenya, Malawi, and Zambia, and Nigeria as well. These are the countries that Dr. Rahul has talked about. He found that the boundaries and names are shown in that figure. Basically, tries to show us how the anemia is, the prevalence of anemia in women of reproductive age between age to 49 years. And of course, of interest is Kenya, where we have 28.7% prevalence of anemia of that particular age group. And of course, the statistics surrounding that value has other various variants in that were sampled to come up with that figure. Okay, this slide shows us anemia in pregnant women, age, of course, the same age, 15 to 49 years. You realize that the anemia prevalence in women who are pregnant slightly goes up in the Kenyan statistics, Nigeria slightly higher, and Malawi as well. Zambia, the statistics slightly going down. Global estimates of iron deficiency anemia and iron deficiency anemia, we realize that the iron deficiency anemia ranges to around 4.6 billion. vis-a-vis the iron deficiency anemia, which is around 1.2 billion. Technically, that is the global data as far as anemia is concerned, published by the Cambridge University Press. Globally, anemia definitely is ranked number 9 because of course, in terms of the mortality and morbidity as well. Yes, so anemia in pregnancy, it accounts for around 70 to around 85% of the cases of anemia in pregnancy all over the world, and especially in Africa. Reason being probably these dietary problems, other chronic problems, that other chronic diseases such as TB, HIV, AIDS, even malignancies also associate, gives us a particular factor or other association to anemia. In sub-Saharan Africa, inadequate intake of diet rich in iron is the leading cause of anemia, among other problems in the pregnant women. Dietary deficiency of anemia is known to, is found to be the biggest, or rather the highest cause of anemia in this particular scenario. Of course, definitely with other causes, as I said, but the amount of diet, the amount of iron in particular in the diet that we do have it in our situations, uh, do not have substantial amounts of anemia, I mean iron, to supplement the iron stores in the blood. Harm. This slide shows us, in summary, the causes of deficiency of iron, and as you can see, we have the first on my extreme left. There is diet and iron malabsorption. Malaria is a tropical problem that we do have in Kenya. Most likely, probably, as Dr. Rahul was talking, he was in India, and I am quite sure malaria is not as problematic as it is in Kenya because of some other reasons. And then we also have hookworm infestation, and this one forms part of what we call the chronic anemia. Chronic anemia, in the sense that the blood loss is not an acute blood loss where you lose blood suddenly, but in the case of hookworm infestation, blood loss is slow and prolonged. And then you also have blood loss probably due to injuries, accidents, or even in the case of maternity issues, you have what we call postpartum hemorrhage. You also have and also antepartum hemorrhage. Basically, you lose blood of substantial amount. You also have what we call maternal fetal bridge of anemia. During the uterine life, intrauterine life of the child, or rather the fetus, is that exchange of blood from the mother to the fetus. And in the situation where there is limited, or rather there is a reduced amount of iron in the maternal blood, definitely the child won't be enriched well. So the growing fetus will definitely lack blood, and the implication will also be felt probably intrauterine, and also after the birth of the child, probably there is some element of growth retardation, weak bones, and all those things. Uh, the map of Africa on my extreme left, there is a particular belt showing the sub-Saharan Africa, and where it is colored red. Colored red means that the malaria, the risk of malaria is noted to be where there is, you can actually see the northern part of Africa where there is absolutely no risk of malaria, which is colored white. And then we also have the yellow part, which is marginal, where some parts of Kenya is actually presented in that particular manner. But a good number of countries are known to be stable, though in as much as the malaria is there, it is not as fatal as other countries. Hookworm infestation, the data shows us. Of interest is Kenya, where the prevalence goes to around 19.9%. Basically, this is a problem that it's usually more of a pediatric problem in our situation, where the children are found to be heavily invested infested with hookworms, especially again in the scenarios where there is an element of poverty, there is poor diets, the poor hygiene. The children are known to have a heavy infestation of hookworms. On my extreme right, the co-infection distribution. Basically, this one tries to match the two scenarios where the child are infested with hookworms, and then as well they also have the coexistence of malaria as well. This one, of course, takes the risk, or rather the implication of malaria or of anemia to be a bit more higher, and probably it runs a more devastating, or rather cause of the disease. In the situation where the child is anemic and also has a malaria, the child also is also prone to lose that child. Uh, this slide uh, it tells us a bit of the data that you talked about earlier on. In sub-Saharan Africa, 24.7% of anemic patients are attributed to malaria. As I said before, malaria is a problem that we have it in Kenya, and in nearly every year, statistics have shown that Kenyan facilities, or rather Kenyan hospitals, at each and every time we have, or at least around 5% of the patients in the hospital are patients who either have malaria or malaria coexisting with other problems, especially in pediatric and also in malaria in pregnant women. So with this, we have some programs in Kenya that are meant to reduce, or rather to create some element of awareness to prevention of anemia, I mean of malaria, so that at least it doesn't get to a situation where people or other patients are heavily a lot of patients in the wards having malaria, which is actually working in Kenya, because malaria is actually a preventable problem by some of the measures that have been put in place by the relevant relevant bodies. Malaria and anemia. A study in sub-Saharan Africa in a child of below 5 years of age reported that moderate severe anemia, it ranges to around 39%, which is actually quite high. Mean severe anemia 3.7, which is relatively low. This one shows us the disease burden, the burden of anemia, of course, with malaria in such countries, Kenya included. Though not every part of Kenya has this problem, because, as I said before, there are some areas that are known to be arid, and then of course they are also dry. And those particular regions, their people are of generally a low socioeconomic status. So we realize that those are the regions that are heavily hit by this problem. In sub-Saharan Africa, between 200,000 and 500,000 pregnant women develop severe anemia as a result of malaria. Again, we usually have, as I said before, the programs that are meant to reduce problems have created awareness, especially during the in pregnant women. We usually advise on the measures that should be taken. But regardless of that, we still have the problems that get to the wards, that get to the hospital in the pregnant women. And then again, in as much as this problem is solvable during the course of pregnancy, we usually try and supplement iron and folate as well to try to enrich the pregnant patients. Mechanism of post-malarial anemia. In sub-Saharan Africa, anemia, malaria, co-infection exists just in the situation where we have anemia and malaria happening in the same time. These are some of the sequences that do happen. This data says that Africa is home for over 80% of the world malaria cases, which is actually true, especially in the sub-Saharan belt that we are shown in the previous slides, where it had been colored red. Those are the countries that have this problem, and then the level of the disease burden in those particular countries is a bit high. So malaria parasite gets into the system, and of course here is through a female Anopheles mosquito that bites the host now, who is a human being, and then deposits the plasmodium. The plasmodium, it's troposid or so. The anti-malarial drugs, which are meant actually to reduce this burden, usually administered, and then you also have the problem is part of what we call the enzymopathies. Glucose 6 phosphate dehydrogenase deficiency actually favors the breakdown of the red blood cells. And then in all these situations, is what we call the oxidative stress that create, and another an oxidative stress that creates an imbalance between the two, and there we lose the red blood cells. So technically, hemolysis happens, and as a massive hemolysis of red blood cells will definitely reduce the concentration of hemoglobin level, and that one manifests as anemia. Uh, 1 out of 4 Africans has a problem, which is actually, personally, I have not, I think I've encountered at least, I think around 3 patients who have this problem. That basically tells us that it is really not a problem in our setup as compared to other parts of the world. Also, post-malarial anemia actually arises due to a massive hemolysis of red blood cells due to the infestation of the red blood cells by the Plasmodium parasite. So again, anemia is responsible for about half of malaria-related deaths. Yeah, this is actually very true. In our country, or rather in our setup, we usually lose patients due to severe anemia, and also plus other complications of malaria that comes probably due to poor treatment, or rather lack of treatment completely, because again we also have a challenge of distance and also availability of drugs, again poverty, so that one makes the treatment be a bit more complicated, and also there is poor, or rather there is no timely intervention to this particular problem. Otherwise, malaria is treatable and it is curable. There are other complications that comes with malaria, such as cerebral malaria. You also have problems of acute kidney injuries. You also have problems of pulmonary edema, such kinds of things. And sometimes you also have jaundice, deep jaundice. Those are some of the complicated problems of malaria that comes, which anemia forms part of it. And then mortalities that are directly related to malaria are way more, especially in the pediatric generation, because of other problems. And then but in as much as that is the situation, it doesn't always mean that any child that comes to the ward having malaria uh, dies. But sometimes, or rather nearly always, we are able to salvage the situation and probably send the child home when they are stable. Okay, talk a bit of about some few information about hookworm. As I said before, anemia that is associated with hookworm infestation is more of a chronic problem, because there's no particular time that the patients will come to the hospital and saying that I have this problem of hookworms. It's most of the time it's an incidental problem, but unless a clinical examination is carried and then you realize the patient is pale, the patient is also getting some element of heart failure or other heart failure related to anemia, nearly all the time the problem is coincidental. We realize the problem while working on other issues. So hookworm burden of 40 to around 160 worms, depending on the iron status of the host, is associated with the iron deficiency anemia. Basically, the hookworm deprives the host the blood. So, of course, the more the hookworms, the heavier the infestation, the severe the anemia that's going to manifest. So, in Africa, among the children with this a particular species of hookworm, what we call Lecata americanus, anemia is prevalent in around 60%, and anemia deficiency is around probably manifest in that particular value, which is around that 3%. Uh, Among children who are infested with the other species of hookworm, Ankylostoma duodenale, and actually this is the particular species that we do have in Kenya. Rather, the commonly encountered one is the Ankylostoma duodenale, and it's accounting to around 85%. So this one data actually is in tandem with the Kenyan situation, where the commonest hookworm that we do find in our population is Ankylostoma duodenale, and most likely these values are also probably something close to the Kenyan data. Having said that, we also need to know who are these people who are at risk to have the problem of anemia. Menstruation, women or women who are having heavy periods. As I said before, this is pure lack of blood loss. And monthly blood loss with patients who are having heavy menses, what we call menorrhagia, definitely will run a risk of having anemia in the long run. So these are the people who need at least each and every time they get supplements, they get diet that's rich with iron, so that it tries to cover their loss that it happens nearly every month. Women with history of abdominal uterine bleeding, multiple pregnancies. Multiparous women run this risk because at least each and every, because during pregnancy there is also the hemodilution and the problem that comes with pregnancies. And then in the terminal time part of pregnancy where delivery happens, they also run a risk of having a blood loss. And then again, people, I mean, women who have had multiple pregnancies, they also run a risk of having what we call the uterine atony, failure of the uterine to contract, and then that one gives us the postpartum hemorrhage, and nearly all the time the blood loss is significant, and that one gives us anemia in the long run. Abnormal uterine bleeding of whatever kind also gives us blood loss in an acute manner, or rather in sometimes the chronic way. So definitely these are people who are at higher risk of developing anemia. Individuals with gastrointestinal problems such as ulcers. In our situation, this is the Helicobacter pylori is a common problem that we experience nearly all the time that we happen to attend to our patients. So he realized that people who have long-standing H. pylori infestation, or rather the gut that is actually having this particular problem, sometimes they do have blood loss to the GI. So recurrency of these ulcers, or rather the people who have had long-standing ulcers, they also has a problem of a risk of having these. Also autoimmune disorders of the gastrointestinal tract, celiac disease, lactose intolerance, lower intestinal tract bleeding, such as bleeding, the problems of also for malignancies. Those other things gives us a problem of anemia in the long run. Again, you also have people who have had gastrointestinal surgery, probably due to other problems. Maybe, for instance, people having malignancies, uh, cancer of the duodenum, cancer of the colon, which is actually a common problem in a situation. You realize these people at some point they may lose some of their the intestinal tract. So absorption of iron becomes a challenge, and definitely this one manifests as anemia. Uh, People with the family history of bleeding disorders, of course, definitely that one is a problem that runs in the family. And in such situations, people are likely to have that problem in the event that it has been happening in the family. Colorectal cancer, which is actually a problem that nearly all the time patients will end up probably having a gastrointestinal surgery, a resection of the intestine, and sometimes even having what you call a stoma, or other colostomy. So there is absolutely no function of the distal part of the gastrointestinal tract, and that is the part that we actually need in the process of absorption of iron. So these people run a higher risk of having uh, anemia. So as a way, probably we need actually to supplement these particular elements in their diet, even sometimes probably in an intravenous manner, so that we reduce the chances. People who are using non-steroidal anti-inflammatory drugs such as aspirin and other blood thinners also run a risk for the obvious reasons. People who have any symptoms of gastrointestinal bleeding, such as dark black, tarry stools, what we call Malina stool, abdominal pain, and also visible bleeding of whatever cause along the gastrointestinal tract, definitely will end with a manifestation of anemia because of the blood loss. How do we suspect that the patient has anemia? Basically, the signs and symptoms. Sometimes we have fatigue, excessive fatigue, weakness, yellow or pale limbs. Sometimes if you are do nearly all the time, we examine our patients, we look at the sclera, you look at the palms, you also look at this, the mucous membranes. You find that nearly all the time it's not as red as it used, but they are pale, they are white. Sometimes we usually say the patient is paper white. That means probably that this patient is severely anemic, and uh, and that's how you pick anemia. Irregular heartbeats. You also have what you call hemic murmurs. If you examine the patient well, find that apart from the normal heart sound, that is the first and the second heart sound, in between you find some funny heart sounds. We call them murmurs, and in this situation, a particular one is an hemic murmur. So definitely that means that the patient has a reduced hemoglobin. Shortness of breath. Uh, Dyspneic patients are who are anemic definitely will tell that that patient is severely anemic. And of course, that one will also mean that there are also getting the complications of anemia, so that probably an heart failure is setting in, cardiopulmonary compromise is coming in. Dizziness and lightheadedness, this is another problem that the patient will come in and complain of. Chest pains, of course, as a late complication, who in patients who are severely anemic. Cold hands and feet, sometimes swelling, headaches are some of the problems. The common signs, you examine the nails of the patient, you have the brittle signs, sometimes spooning, sometimes what you call mook and nails, cracks of the side of the mouth, angular cheilitis also comes in, pale skin, as I said before, swelling and soreness of the tooth. But that one is more characteristic of what you call megaloblastic anemia and gives us the soreness of the tongue in that scenario. Diagnosis, of course, the physical examination has to be done, and you'll elicit the features that we've just talked about. Um, and then, of course, there are blood tests. A basic hemogram, what we call a full blood count, should be able to tell us that. Of course, the HB will be low, what we call the hemoglobin. You also need to also look at some of the red cell parameters, what we call the MCV, that is mean corpuscular hemoglobin. We also have what we call MCHC, mean corpuscular hemoglobin concentration. And definitely all those things will be low because of the reduced hemoglobin. Hematocrit concentration will also go down. Harm. The tests, various tests, of course, after the hemoglobin, you also need to do the individual red cell store, the iron stores in the blood, and probably that one can also be a more definitive way of assessing, rather diagnosing anemia in that particular scenario. Of course, after that, you also need to institute treatment, and treatment basically means you substitute iron. And in the event that the patient has now had complications of anemia, you address the problems, the complications individually, and then you also need to do what we call a follow-up. A follow-up means basically you follow up the patient and ensure and have a repeat and a review, subsequent reviews of the patient, so that we ensure that the treatment that was given to the patient is actually working with the patient. Uh, Complications of iron deficiency anemia. In the event that the problem is undiagnosed or misdiagnosed, or is diagnosed but treated, not treated as it is required, these are the problems that are likely to set in. Depression, of course, is a mental problem that the patient will likely to run in the event that there is no timely intervention, or rather the correct treatment of anemia. Heart problems like irregular heartbeats, heart murmur, enlarged heart, and even heart failure. Heart failure is actually the ultimate problem, where the patients start having a failing heart. They start now having dyspnea, they have difficulty in breathing, they also develop lower limb swelling, sometimes a grossly swollen abdomen with cholestasis. Those actually comes as a result of a purely untreated anemia. You also have a risk of infection, basically because of the compromised state of the body, and that one will result in the body's inability to fight, rather to mount a very good immune response to any offending agents. Uh, Motor and cognitive development. This one definitely means that in the event that the anemia appears in children, there is some element of growth retardation. Rather, the growth is actually hampered and it is curtailed by the problem. Pregnancy complications such as preterm deliveries. You also have underweights of children that are born below the expected birth weight. Sometimes you also have what we call IAGR, intrauterine growth retardation, and there were situations we also lose the patient, I mean the fetus, what we call the intrauterine growth fetal demise. That is the presentation that we had for tonight. I mean for right now, and then I will also want to hand over the presentation, rather the talk, to the next presenter, and then we'll entertain a few questions and we will respond to them. Yeah.
Yes, ma'am. You can share the slides.
Okay.
Um, can you see?
Yep.
Yeah,
I
we
see.
can see it.
Yeah. So thank
You
you so
can,
much.
ma'am,
Sorry.
you can just hit on height over there on this bar. Height. Okay, perfect. Thanks.
So we have had a detailed understanding of what iron deficiency anemia is all about. Now let us look at what are the dietary inhibitors of iron absorption and their mitigation mechanisms. Now, we have, pardon me, I have a bad throat. Last 20 minutes, we have heard about various reasons why iron deficiency anemia can happen. And the other than worm infestation and malaria and other things, accidents and drugs, the most important thing is nutritional reasons. And we find that a lot of times dietary habits which are indigenous to the region can actually lead to anemia in this population. So look at iron and health. An essential element, iron is an essential element of various metabolic processes in humans, which include DNA synthesis, electron transport chain, and oxygen transport. Iron levels in human body are controlled only by absorption. Iron exists mainly in erythrocyte as heme compound hemoglobin. So these are basics of iron. Now we know that dietary iron is of two kinds on its own. Heme iron. Now heme iron is derived from hemoglobin and myoglobin. Myoglobin is the hemoglobin of the muscle because myo is muscle and globin is the protein which is linked there. So all animal sourced food like meat, seafood, poultry, they are all sources of myoglobin and these are most absorbable form. Now lot of times question is asked, why are they most absorbable? The exact reason is not known. Most probable reason is because they are latched on to protein. So their entry into the cell is much easy. They are more absorbable form 15 to 35% and it contributes 10% or more of total absorbed iron. The other iron is non-heme iron, which is derived from plants and iron fortified foods. Now, if you look at these are absorption enhancers and inhibitors. So, which are the dietary enhancers and inhibitors? Let us look at them in detail. The enhancers of iron absorption are meat, poultry, and fish because the iron in them is in heme form. Another very, very important enhancer is vitamin C because it reduces the iron form and it aids its absorption, and alcohol. The inhibitors are phytates, and for a population who eats a lot of cereals, Africa, like India, is typically, based on the diets are typically based on cereal intake. So it can be wheat, it can be rice, it can be other grains, but all the grains, remember, because they are seeds in nature, they are very rich in phytates. Okay, so and inositol phosphates, that is IP3 to IP5, and these are major inhibitors of iron absorption. Polyphenols and other flavonoids, which are present in things like teas and coffees and etc., they are also major inhibitors. Now, again, globally, teas and coffees are taken around meals as well. So people end their meal with a cup of tea or coffee, and these actually starts inhibiting the absorption of iron in that meal. Eggs contain phosphovitin, which again can inhibit absorption of iron. And we all know that calcium and iron are mutual inhibitors, and therefore, adding calcium or dairy products to your iron rich foods will inhibit its absorption. Then there are host-related enhancers and inhibitors. So enhancer are iron deficiency anemia itself. So when an individual has iron deficiency anemia, they will absorb the last bit of iron which is given to them in their food. So low body store, like a lower ferritin level. Gastric acid. So as acid is very important for good absorption of iron, and that is why when you see when iron is taken empty stomach, the absorption is better, but then the side effects are more. Then bile and pancreatic secretion, hypoxia. Individuals who live at higher altitude actually absorb better iron. Pregnancy, again, we know that in pregnancy, the need of iron is more high and therefore absorption is better. So wherever body or the host demands are high, remember body will absorb iron much better. Then increased erythropoiesis, especially after blood loss, whichever kind, maybe like an accident based blood loss, or if there is any other surgery based blood loss. And then there is homozygosity and mutation. Then there are inhibitory factors. For example, high body iron stores. So you start seeing that when you start supplementing iron to somebody with anemia and very low hemoglobin, initially it picks up very, very fast, and then you continue giving, and then the rise is very, very slow. Previous high intake of iron and any kind of drugs which cause rapid gastric emptying, because it takes time for iron to be absorbed. Now, these are common dietary absorption inhibitors. So, the most important among them is phytates. So, remember, whenever you are eating a non heme iron food, say a green leafy vegetable, and also it has a lot of phytates in it, remember, due to phytate, there will be loss of iron absorption. So the negative effect of phytate on iron absorption is actually dose dependent, and it starts at a very low concentration of 2 to 10 milligrams per meal. And that much phytate you will find is in simple, like a loaf of bread that you are eating, like a roll of bread that you are eating. Or maybe if there are millets which are eaten, it will cause the same thing. Polyphenols occur in vegetables, fruits, some cereals, legumes. So, like India, even Africa eats a lot of legumes. And legumes are also very, very rich source of both polyphenols and phytates. Tea, coffee, wine, black tea, herb tea, both inhibit iron absorption. And it is very, very fashionable nowadays to drink herbal teas. In cereals and legumes, polyphenols add inhibitory effect to the phytate. Calcium has a negative effect on non-heme and heme ion absorption, which make it different from other inhibitors that affect only non-heme ion absorption only. So remember, phytates and polyphenols have a huge impact on non-heme ion. But when you take in calcium, you will realize calcium has a greater effect. I mean, it has an equal effect on both heme and non-heme ion absorption. Then proteins. Animal proteins such as milk protein, egg protein, albumin have been shown to inhibit iron absorption. Two major bovine milk protein fractions, that is casein and whey, and egg white because of phosphovitin, have shown to inhibit iron absorption in humans. Now look at these. These are your traditional meals. So they will have, say cereals in form of bread, or porridges or gruels, which are in form of cereal intake. Again, so green gram, which is again a legume, beans, which is again a legume, all these becomes our dietary inhibitors because of the phytate and the polyphenol and the raisins and the tannins in them. Yeah, same is true for meals in Nigeria. So if you're seeing different kinds of beans, I don't have to tell you this is the food that you eat. So they contain a lot of phytates, tannins, polyphenols, etc., which are going to inhibit. So uh, be assured that these are healthy foods. But if somebody is having anemia, these are not going to help them to overcome. This is food in Ghana. And again, if you look at it, millet cereals or whole wheat, like I said, among them, rice is a little bit better, but other, all of them will actually inhibit absorption of iron. Now, what is the treatment of iron deficiency anemia? Or what are the how to nullify the effects of these dietary fibers? So, what are the strategies? The first strategy is increasing dietary supply of iron rich food, which among animal sourced one offers highest bioavailability of iron, but their cost and availability is a major concern. So yes, iron rich foods which are coming from animal sources, like various kinds of meats, various kinds of poultry, various kinds of fish, these are foods which can increase availability of iron, but again they are expensive foods. Proteins in general are very expensive. Delaying the cord clamping at birth is a simple but efficient mean to increase infant's body iron stores. So remember, as soon as the baby is born and the cord is cut, it has to be clamped so that blood loss is minimized. Iron supplementation is recommended by World Health Organization for populations living in settings where anemia prevalence is over 40%, including menstruating women, postpartum women, and children above 6 months of age. And we just saw statistics for whole of Africa, where we see that in most of the regions there is prevalence of anemia, which is about 40%. So it is very important that you talk about iron supplementation. Like in Africa, even in my country, in India, there is huge iron deficiency, huge prevalence of iron deficiency anemia, and therefore even in India there is a lot of government initiative to give iron to population in general, but more specifically menstruating girls, postpartum women, and young children. And fortification of stable food. Now, this will become very interesting. I do not know how much fortification you have, but if you can fortify staple foods like wheat or maize, okay, with iron sources, then you will find that unknowingly people will land up eating iron, okay, and this kind of food will actually help them to increase their iron stores. What are the benefits of iron intervention? In pregnancy, benefits are huge, because in pregnancy there is something called as dilutional anemia. Blood volume increases and therefore every woman sees anemia. So there is a decrease in maternal anemia, increase in infant's birth weight, and that, what does that do? That actually improves cognitive capacity of children under 2 years of age. In childhood, it improves age adjusted height as well as weight among all young children. It improves global cognitive scores, intelligence quotient, that is IQ, and measure of attention and concentration. So you'll find that most of the time, if the children have low hemoglobin, they are unable to concentrate and their academic performances actually suffer. Now, with all this as a background, then we look at type of iron supplementation. So they can be given as oral iron, which is easiest to give, intravenous iron, which is difficult to give because you need them to get admitted to hospital and then be given. Then, of course, there is blood transfusion, and stages of iron deficiency should be considered before a treatment is offered. So, for example, for mild anemia with hemoglobin up to 8, 7, oral iron is given, IV iron is given when the situation is that hemoglobin is very low, maybe in a pregnant woman, and so on and so forth. And blood transfusion, of course, when there is accident or a lot of blood loss. Treatment option depends upon patient's hemoglobin levels, tolerance, and comorbidities which are existing. Now, oral iron supplementation are usually the first line of treatment for uncomplicated iron deficiencies. So, we know that there are conventional iron salts. So, this is ferrous sulfate, ferrous fumarate, ferrous gluconate, and this is something that we have been using for a long time. Now, these are new oral iron salts: sodium ferridate, sodium bisglycate, carbonyl iron, iron polymaltose complex, and ferrous ascorbate. These are newer kinds of salt. So for iron deficiency anemia, we are looking at it. It is not only for, it can be for macrocytic anemia. We are specifically looking at folic acid and vitamin B12 supplementation. But for microcytic anemia, we are looking at these various salts which can be used. What are the limitations of these conventional salts like sulfate, fumarate, and gluconate? The problem with them is that in a population which eats a lot of cereals, like in Africa or in India, you are vulnerable to interaction with food, leading to reduced iron absorption. So the individual may even take supplemented iron, but if they take iron with the foods which contain a lot of cereal like wheat and millets and rice and vegetables which are usually rich in phytates and polyphenols, then this supplementation will be downtoned on its own because of huge presence of phytates. Bioavailability is only 10 to 15%, and therefore, what happens? One needs to take higher doses. Up to 50% patients on oral iron report gastrointestinal side effects. And for this August audience, I don't need to tell you, in India, people complain of bloating, complain of constipation, acidity, nausea, vomiting, as much as even pregnant women are not ready to take it because of these side effects. There's a reduced tolerance and adherence to iron supplementation. So these are very, very important things to understand. Dietary factors play a role in development of iron deficiency and subsequently development of iron deficiency anemia. So therefore, we know these are the problem. We know that foods which are animal based are expensive. I do not know the prevalence of vegetarianism in African countries, but in India, vegetarianism is both religious and sometimes ethical. And I have seen so many times that ethically, when people become vegans, not even vegetarians, we find that their hemoglobins drop if they do not supplement it. In my practice, I have many such patients which have come to me. So, should we avoid a diet? Big no, we cannot avoid diet. Should we take high doses of conventional iron salts to tackle the effect of iron absorption inhibitors? Partially correct, but it will increase the risk of GI side effects and patients' non-compliance. Understand, friends, moment there are GI side effects, patient will become non-compliant. Moment there is nausea, patient will say, I don't want to take it. Moment there is bloating or there is severe constipation, patient will say, I will not take it, it doesn't matter. Because sometimes hemoglobin of 9 and 10, if it is there for a longer time, patients do not even start seeing any symptoms of it. They do not feel exhausted. Like doctor just said before my talk, that he saw somebody with a hemoglobin of 2 in one of his practice, and even then that child was playing and running around. So probably body gets used to having low iron, and patients do not realize the gravity of what this low iron can do. So we should look beyond conventional iron salts for iron deficiency anemia. Of course, we should, due to their widespread availability, efficacy, and safety. So the new iron preparation is sodium ferritate. Okay, so you could call it old wine in a new bottle, and old wines, as you know, are far better than new wines, even if they are in an older bottle. So sodium ferritate has unique properties. What are the properties? They are water soluble, they are highly bioavailable. See, what is very important for any kind of nutrient is its bioavailability. So it's highly bioavailable form of iron. It has minimum impact with dietary absorption inhibitors like phytates, tannins, calcium, so on and so forth. So your patient doesn't have to worry whether they are taking it just after milk, or maybe they're taking it with a bowl of gruel which is made from millets, or which is made taking it with a loaf of bread. It doesn't matter. A study reported that in addition to calcium to maize based test meal had no significant effect on iron absorption when it is given in form of sodium ferritate. Now, sodium ferritate is also food fortification. Food fortification of iron compounds impart metallic taste to the food and are poorly absorbed due to common dietary inhibitors in the absorption. Because if you're going to add it to, say, wheat flour, or you're going to add it to, say, maize flour, there are two problems. One, it will not taste good. It will taste weird. And moment it tastes weird, then if it doesn't taste good, people are not going to eat it, and they are poorly absorbed if you add any form of dietary inhibitors to it, like phytates, which are present. And therefore, A expert panel, because these were a problem to adding iron salts to normal food, expert panel actually recommended sodium ferritate as a only suitable form of iron to fortify whole grains, and this was actually endorsed by WHO, and that goes a lot to say, my friends, if something is endorsed by the World Health Organization. The main advantage of what is the main advantage of sodium ferritate? Absence of metallic taste. See, in India we say when it comes to food, taste is the king. So if it tastes good, people are going to take it. And high level of iron absorption, including in phytate rich diet. Now, if you're going to fortify like a maize flour or a wheat flour, it's already phytate rich. You have to fortify it with iron salts, which are going to be absorbed despite of its phytate rich nature, and that is what sodium ferritate actually gives you. So sodium ferritate mechanism of action, it is stable in acidic environment and hence no dissociation of sodium ferritate complex in stomach. So in stomach, it is actually firmly attached to the EDTA. Iron absorption begins where iron is made available to the mucosal cell. The free EDTA then, once it is separated, the EDTA acts as a shuttle and picks up more iron, copper, zinc, and it delivers to mucosal cell. So it just does not take care of iron, but it takes care of other elements like copper and zinc. And you know, in today's day and age, with so much of COVID-19 all around us, zinc is a very, very important micronutrient. Absorption of iron is not only inhibited by other inhibitory ligands like phytates, tannins, and calcium. Therefore, iron is insulated. It's like hidden or insulated with sodium salt of EDTA to form a chelate, and therefore sodium ferritate is not astringent and does not even discolor teeth. Now you will see that sodium ferritate in EDTA is a very strong chelator of iron. It passes the stomach intact. It does not get dissociated because it is a strong chelator of iron. In the duodenum, it splits into iron and EDTA. They separate out. Free EDTA chelates with intrinsic iron to assist its absorption. EDTA also binds with other minerals like zinc and copper for their absorption. More than 95% of EDTA molecule is secreted into feces, and you should not be worried about safety of EDTA. It has been shown that about 1.6 milligram per kg body weight per day of EDTA is safe for consumption. It is regularly used as a food additive and it is safe for consumption at all ages, starting from about 6 to 7 months of age. And therefore, don't worry about this EDTA bothering you. Sodium ferritate remains fully soluble in presence of iron absorption inhibitors like phytate and thus hitting intestinal cells continuously, which separates iron from EDTA, absorbs the iron and leaves out EDTA molecule. Now, what is we need some see we are all living in evidence-based medicine world, and these are few evidences about how they are good. So studies in children reported that iron salts, when given with a milk rice sugar formula, the mean absorption of sodium ferritate was 8.6% as compared to iron ferrous sulfate, which was just 3.3%. Studies in adults reported that iron salts, when given with a meal consisting of beans, tortillas are corn breads or bread, and coffee. So these are all inhibitors which are high in phytates, polyphenols, all of these. So beans, tortilla, bread, and coffee. Iron absorption was 2 to 3 times better with sodium ferritate than ferrous sulfate. In children and adults, sodium ferritate offers better iron absorption than conventional salts like ferrous fumarate sulfate. So these are definitely better than ferrous fumarate. This is also being shown in pregnant women, the group which requires iron the most. So sodium ferritate versus for ferrous fumarate effect on hematological parameters. So what did they do? Pregnant women with gestation period between 12 to 26 weeks having a serum hemoglobin of less than 10 grams per deciliter. Group A got sodium ferritate containing 33 milligrams of elemental iron with vitamin B12 and folate. Group B had sodium ferritate containing 66 milligram of elemental iron with vitamin B12 and folic acid. And Group C had ferrous fumarate containing 100 milligrams of elemental iron. So look at it, 33, 66, but here 100. So about, if you compare it to 33, about 3 times more. And if you compare to 66, it's about 1.5 times more of with vitamin B12 and folic acid. So what was shown that low doses of sodium ferritate, 33 and 66 milligrams of elemental iron given twice daily leads to same hemoglobin rise as high doses of ferrous fumarate. Sodium ferritate appears to be effective in improving hemoglobin profile in pregnant anemic women and also is tolerated well. So look at this. This is with 33. Of course, group B got more iron, elemental iron of 66, so hemoglobin rose slightly more. But look at group C getting 100 milligrams of ferrous fumarate actually rose the least among all the three. And that is also because these women were eating other inhibitory foods like cereals, etc. Sodium ferritate versus ferrous fumarate effect on other hematological population parameters. So pregnant women with gestation period between 12 to 26 weeks having hemoglobin less than 10, sodium ferritate containing 33 milligrams with B12 and folic acid, ferrous fumarate 100 milligrams with B12 folic acid, low doses leads to twice as rise in ferritin levels and RBC levels higher than that dose of ferrous fumarate. So whether it is rise in ferritin level, that is your stored form of iron, or actually the rise in the RBC count, million per cubic millimeter, you will find that individuals who consume sodium or pregnant women who consume sodium ferritate actually had a far greater rise. Again, the same thing, antenatal women here with gestational women age of 24 to 32 weeks with a hemoglobin which was lower, 8 to 9.5 gram percent were selected, and study 2 had pregnant women with anemia, and you find that sodium ferritate led to a higher rise of hemoglobin with better gastrointestinal tolerability with lack of metallic taste than ferrous sulfate. So with sodium ferritate, there was a rise in the hemoglobin of the patients with anemia. And if you see, this is ferrous sulfate now, the color. So you see, these were 20% of people were experiencing metallic taste, 0% actually experienced metallic taste when ferritate was used. Then 3% patient experienced vomiting, 40% of patient experienced constipation. And believe me, friends, moment there is constipation, women stop taking this iron supplement. And about 13% of patient also experienced diarrhea. So what is the take-home message? Iron levels in the human body are controlled only by absorption. However, dietary inhibitors like phytates, calcium, tannin, polyphenols actually reduce iron absorption. Dietary factors play a role in development of iron deficiency and subsequent early iron deficiency anemia. Conventional iron supplements are significantly affected by presence of dietary absorption inhibitors such as phytates, tannins, so on and so forth, and are associated with higher GI side effects because you need to give them in higher doses like metallic taste, which leads to non-compliance. Due to these dual drawback, conventional iron supplement can be overcome by use of a new iron salt. Sodium ferritate is one such iron salt. What does it do? Just as a take home message, it protects from the dietary absorption inhibitors. It has a better absorption rate, and we have enough evidence based studies to show that it has better GI tolerability and it is devoid of metallic taste. And due to these four reasons, it ensures higher therapy compliance. And friends, we all know higher the compliance will only solve the problem, just not giving iron to the patients. Thank you so much for a patient hearing.
Thank you so much, Dr. Kibet and ma'am, for for taking us through this wonderful session back to back, starting with very basics coming from Dr. Kibet, taking us through starting from the definition of anemia to different aspects of this disorder, as well as your valuable literature-based facts and figures, Dr. Kibet, which you put forward. I really appreciate that. And thanks to ma'am for for presenting very eye-opening data on how diet, which we consider as a part of our life, which is essential for us to survive, can hamper the iron absorption, and how it should be seriously considered if someone is having iron deficiency or iron deficiency anemia, and the unique features of this novel salt, sodium ferritate, which you have presented. I'm sure our audience is going to take very important take-home messages from this session. Please allow me to take a few questions asked by the audience. The first question is for Dr. Kibet. Which is more reliable blood test for anemia diagnosis?
Eh, okay.
Whether, like, for example, whether it is hemoglobin, or one should always go for ferritin, or if any other test you would like to recommend.
Okay. I would actually recommend a complete blood count so that we capture the level of hemoglobin. But of course, in a setup where the available structures and facilities and equipment are there, going way forward to detect the level of ferritin is actually even the ideal situation. But for a random diagnosis, I think a complete blood count and a full hemogram is adequate.
Perfect. Ma'am, would you like to add? Uh,
So I do not know about the situation in other places, but in India we actually do the complete blood count, like Dr. Kibet said, and then depending upon what we find in the complete blood count, we take a call if we actually really need to do ferritin and other levels.
Okay.
We understand whether it is microcytic, macrocytic, even if it's nutritional or non-nutritional, and then we take a call whether we have to do iron studies further.
okay. Perfect. Let us move to next question, where it is. I, it can go to both the speakers. What is the place of oral iron supplement in the treatment of severe anemia?
Okay. In the situation where we have a patient with severe anemia, usually the treatment is more of a resuscitational. It's a resuscitational sort of a treatment, and you want to correct the anemia immediately. But the question of having oral medication, yes, it is still ideal, but the correction will not be timely. So definitely
Yeah.
you'll want to probably address the anemia by probably even a blood transfusion,
Hmm.
supplying packed red blood cells intravenously, and then and probably way later you may need to consider the oral drugs.
Correct.
Okay, ma'am, would you?
I completely agree with Dr. Kibet that there are
Okay.
situations where you
Mm-hmm.
need to give parenteral formulation or you need to give packed cells. Say patient is posted for surgery or there is injury or whatever, but or even in pregnancy sometimes. But
Okay.
if it's not a life threatening situation and you have some time on your hand, oral is the easiest, safest, requires no admission. So that way,
True,
it's a very ideal situation. But we all know all situations are not ideal. So we have to weigh the
Right.
pros and cons and decide what which situation demands what kind of therapy.
true, completely.
Okay. So now, since question is related to the severe anemia, so talking about this severity wise, like mild, moderate, and severe situation, where I guess that decides the duration of oral iron supplement. So in your individual practices, what is the usual duration of oral iron supplement you recommend?
Okay, in our situation or in our setup, usually in the event that the patient is severely anemic and you've transfused the patient, you've given them parenteral packed red blood cells or whole blood, usually you want to do a follow-up on such patients probably for like a month or 2 months, and in that duration they are also on oral medication. So usually we follow them for at least 2 months or rather 6 days on their oral medications.
And for mild to moderate, Dr. Kibet?
Mild to moderate, usually we would, the timeline is still the same, probably at least a month. But this time round, of course, the duration, I mean, the follow up might not be that prolonged because of we anticipate correction of anemia way earlier
Yeah.
than the patient who is severely anemic.
And ma'am, your views?
So I agree with Dr. Kibet, but I tend to give it a little longer because I want the ferritin levels also to come up. A
Okay.
lot of
Okay.
times we find both are the problem. Hemoglobin is a problem, but ferritin levels are also problems. So sometimes not 1 month or 2 months, maybe about 3.5 months. But we check for all this. Once we start
Mhm.
supplementation, we redo a CBC and maybe a ferritin level to see if we are getting what we achieved. Also, I would like to add that besides iron, India is a predominantly vegetarian country. People most of the time are vegetarian. So in India, macrocytic anemia is also very common because of deficiency of vitamin B12. Because
Okay.
vegetarian food does not provide vitamin B12. And
Mhm.
therefore,
Absolutely.
a lot of people don't take it otherwise, and then they have macrocytic anemia. And for that, then also we require to give vitamin B12 in a prolonged uh, duration.
Absolutely.
Fine. Uh, Next question is for you, ma'am. This is about this salt, sodium ferritate, where it has higher viability, and so does it mean that it will be effective even at low doses as compared to conventional iron salts?
So it has been shown, right? I showed two studies where, as compared to ferrous fumarate, which was given 100 milligrams, this iron salt was given at two concentrations, 33 and 66. And even then, it showed a greater rise. So even if you consider the lowest concentration of this salt as 33 milligrams, even then it is being more efficacious than other salts. Of course, if you give it as a full dose, 66 milligram, then you will have much, much better results.
Right. So,
Thank you.
uh, the reason behind this, ma'am, again, it might be because of the uh, chemical nature of this chelate which is formed, right?
Correct.
Yeah.
And
The
yeah.
main reason is
Correct.
that it is not getting inhibited. See, the thing is, when people are not doing well, the emphasis on eating food is a lot. So naturally, if a girl in the house is pale and she looks anemic, the mother wants to feed her, correct? But
Yeah.
she doesn't know what to
Sure.
feed. So she's going to feed greens, she's going to let her drink milk, and this is all happening while she's taking iron. And what is it leading to? It's actually counterproductive because it is
Yeah.
leading to lowering of the absorption or bioavailability of iron. In such cases, what you can do is if such salts are given, whether they are drinking milk or they are eating greens or maize with it, it will not impact the bioavailability. So, mother's love and iron can go hand in hand. No inhibition of each other.
Sure.
Right. Perfect. So, ma'am, considering these all features, and you also have presented some data coming from different kind of patient populations. Um but since there is a question about the safety of this iron, can it be taken by all age groups?
Yes, it can be. So studies have shown that 6 months onwards, I guess, they can be taken easily, and do not worry about the EDTA part of it. Like I said, EDTA is a natural food additive. Amount of things we eat from outside and pre-processed, we are eating enough EDTA. So this is just one more add-on, but this is again medically there. So I mean, it has been tested and proven. So I don't think there is any reason to worry.
Right. And I do remember you mentioned in one of your slide that around 95% goes unabsorbed,
Waste.
in it get
Yeah,
passed in
in the
stool.
feces.
Yeah.
Sure.
Right. Fine. So, moving on to next question here, how much spacing should be there between iron and calcium, or
So
maybe
if
iron supplement and milk consumption?
if you're using this iron supplement, then it doesn't matter, right? But if you're not, then ideally a calcium and a iron should be at least 3 hours apart. At least
Okay. At least
more
three
the
hours.
better. But the point is, uh, I again don't know much about Africa, but in India people tend to eat every 2 3 hours. They'll eat
Okay.
something or the other. So your stomach is never empty. Okay, so food is very, very important. And I'm pretty sure the same thing goes all across the world. So, we are
Exactly.
ultimately doing all this hard work for food, right? So people
Yeah.
want to enjoy it. So if you're going to eat continuously, you're going to eat one inhibitor after the other, and none will
Mm.
get absorbed. So at least iron and calcium, try to space it at least 3 hours apart, even if
Yeah.
you're taking it as an oral agent, so as a supplement. So you're taking calcium carbonate and you're taking iron supplement, space it away. If you're taking like a glass of milk and then you want to take an iron tablet, space it away. Ideally, iron tablets should be taken with a glass of lemon water. So squeeze lime in water or lemon in water, or maybe orange juice if there is no diabetes, and you can have it with something which is vitamin C rich to ensure absorption, but not if the salt is with EDTA. Then you don't have to worry at all.
Okay.
Perfect.
And there are few more left now. Like this question can be taken by both the speakers. Like, why are the hematinics or iron supplements are not taken together with antibiotics?
Okay. Uh, I would want to say probably the reason behind that is the bioavailability of the drugs, because the antibiotic is likely to be the antibiotic metabolism and absorption is likely to be interfered by the hematinics. So usually we wouldn't want to have the two being co-administered in the same situation. Yeah.
My understanding is whenever there is an infection, iron supplementation is stopped, because if typically in bacterial infection, bacteria tend to use this iron to grow well. So, moment there is any kind of bacterial infection, iron supplementation is stopped, and when there is bacterial infection, only then antibiotic is given. So it all goes hand in hand, right? You are not going to give an antibiotic for a viral infection. So when there is bacterial infection, so that the
Yes.
availability of iron should be dropped for the bacteria. Bacteria, like human, requires
Yeah.
iron.
Yeah.
So once it is starved, the growth will stop. Antibiotic will kill it. As it is, taking an antibiotic gives you 1 million GI symptoms.
Yeah.
You're getting a bad
Okay.
stomach. You're getting nausea. You're getting vomiting. Then
Understood.
you don't want
Yes.
to add iron to the problem. So let that get over, give it a 2 days gap, and then start iron all over again.
Fine. And I will take up now the last question here. Why do some people not constipated while they are taking iron supplement? At more than 90% complain of constipation while on iron supplements.
Can I take it?
Yes, please.
Yeah, you can.
Yeah. So what I have realized, and this is over years of my practice, that when somebody's hemoglobin levels are like 7 and 6 and low, very low, right? You give them iron, they have no constipation, because their iron absorption is complete. I mean, body is going to take as much as it can take. That was one of my slides. Lower the hemoglobin, better is the absorption. Body
Yeah,
features.
yeah.
But moment you see their iron coming back, hemoglobin coming to 10, the problem of constipation starts, because now body does not need as much, so lot more is thrown in feces unabsorbed, and that is
Okay.
what is causing constipation. But besides that, people who drink very little water, and it's a very common feature, at least in India. I do not know about Africa, but there are people who barely drink 2 glasses of water in a day. Just because they have to take a tablet, they drink water. Otherwise, their fluids are tea and coffee through the day. So, such people will get constipated more often. People who are physically inactive tend to get constipated more often, and also people who do not eat enough fiber rich food. But fiber rich is a two-way sword. Fiber is phytate. So
Yeah.
if you eat a lot of phytate, you're not going to absorb iron. But at the same time, you're going to get constipated. So it is going round and round in circles. What came first, the chicken or the egg? It's that story. So that is why choosing a better salt, so that you can eat what you want and not get constipated. You can eat a lot of greens, you can eat a lot of pulses, legumes, which has a lot of fiber in it, which will not let you get constipated. And please drink a lot of water, because water, once it goes in it, fiber swells, and that will increase the bulk of the stools and prevent constipation.
So, in a nutshell, ma'am, for this particular question, is your fiber rich food, lot
And
of
water.
water, and
Yeah.
and iron salt which can be taken with fiber like sodium ferritate.
Yes.
Perfect, great. Thank you so much. Thanks once again to the speakers for handling all these questions with all your interest. We can see here very clearly, and this is indeed very serious topic. Usually, ma'am, nutritional disorders are not taken that seriously, uh,
But
and
I think
but
I should end
yeah,
it with just one last word. What
please, yeah,
Hippocrates said:
yeah.
"Let food be thy medicine."
Sure, he said so.
Yeah.
Yes, that is very important for everybody to understand that food should be treated like
That
medicine.
amazing.
Exactly, exactly. And this is one of very few nutritional disorders which can even lead to death, right? We have seen the
Yes,
figures, facts and
yes,
figures, right? So, but at the same time, it is not that seriously taken. It is neglected. But I'm sure this session coming from both of you will add immense level of knowledge on the subject matter on dietary factors, how they affect iron absorption, and sodium ferritate, what role it is playing in this entire process. Thank you so much once again. Thanks to all our audience for making this webinar series a big hit. Stay tuned to all our programs. Keep on sending your suggestions. We are getting many suggestions, right? So you can reply to the emails which you are getting. We are going to share the recorded file of this webinar, which you can share with your peers if they have missed attending this live session. And we'd also like to pass on our sincere thanks to accrediting body with CMA and CPD points. Thanks. Thank you so
Yeah.
much. Have a good day.
Have
thank
a good day
you.
too.
Thank you so much.